Okay, so today we're going to tackle a new case, and we're going to integrate between step 1 all the way down to step 3 with some extra integration questions as well. So let's break into it. We have a 62-year-old man. He presents with long-standing type 2 diabetes and hypertension. He has fatigue and worsening exertional dyspnea. He has stage 4 chronic kidney disease. He denies melena or hematochezia. On exam, we see conjunctival pallor, no hepatosplenomegaly, no lymphadenopathy. We see hemoglobin of 9, hematocrit 27, MCV 89. Retic count is 1.0, ferritin 145, TSAT 18. Calcium is 8.1, phosphate is 5.8. PTH is 420, the BUN is 45, creatinine 3.4, platelet count 210,000, and his platelet aggregation assay is abnormal. So right off the bat, before even jumping into this, I think it's good to have a schema for anemia, because that's what a lot of our questions, if you've looked at the questions, they're going to tackle a lot of why this patient has anemia and some other problems as well. But my framework for anemia, one, let's consider what is anemia, right? So anemia is low hemoglobin circulating through the body, right? It's defined as less than 13 in men, less than 12 in women, and less than 11 in pregnant women. Anemia, a patient may present with dyspnea on exertion or just straight up dyspnea. They may have tachycardia. They may have conjunctival pallor, kind of things like that. With regards to anemia, I think anemia should always be on your differential. When you have a patient who has a chief complaint of dyspnea, it's a good one to add, and it's real easy to screen for, right? We just get a CBC and we can see, does the patient have anemia? It gets a little bit trickier than that, though, because there are so many different causes of anemia. So I like to break it down schematically, right? So I'm going to teach you my schema to think through anemia. So we can break it down as MCV based, right? So mean corpuscular volume. A mean corpuscular volume less than 80 is microcytic, between 80 and 100 is normalcytic, greater than 100 is going to be macrocytic, right? So what's my differential for microcytic anemia, right? So I get a hemoglobin that's low, I get an MCV that's 75, right? I'm thinking about my tails mnemonic. Thalassemia, anemia of chronic disease late in the course, iron deficiency anemia, lead poisoning, sideroblastic anemia. So real briefly, like some of the pathophys, right, in our thalassemias, we have alpha and beta thal. Alpha thalassemia is found in chromosome 16. Those globin chains are made. There's 4 of them. The more chains that we get defeated, or the more chains that are destroyed, the worse off the prognosis is. In beta thal, right, there's 2 chains made on, or 2 globin chains made on chromosome 11, right? Obviously, if both are knocked out, we're going to have some problems, right? Those make up our backbone of our hemoglobin molecule, okay? So less of those globin chains, less of our hemoglobin, and you can kind of see where that's going. With regards to anemia of chronic disease, right, I'm going to save that one for later because that's one of our integration questions on how that works, but that can also lead to a microcytic anemia later on in the course. Iron deficiency anemia, iron makes up a big portion of our heme molecule, right? We have a ferrous iron right in the center of that heme molecule. That's going to be super important, right? So a patient can lose iron for many reasons. The biggest one is going to be bleeding, right? So we check for hematochezia or melena, right? Losing blood through the stool. We can do a stool guaiac test if the blood is not visible to the eye, but we can see it on a guaiac test. Women can lose blood through the endometrium, right? So they could have heavy menstrual flow, or patients who just have internal bleeding that we can't even see, or patients who are iron deficient just due to dietary reasons, right? Many different reasons, and that could be a whole lecture on its own, which maybe I'll do at another time. Lead poisoning, so lead is common, was used in a lot of houses made usually like before the 1970s. People who are around lead for job get exposed for it and sometimes can bring it back, right? Lead can cause neurological and GI symptoms. It can also cause a microcytic anemia. This is because lead will inhibit ALA dehydratase and ferrochelatase, which are both important enzymes in making heme. So we can't make heme, right? We can't make the big majority of my hemoglobin and my red blood cell, right? So you can see how that's going as well. And then sideroblastic anemia. Sideroblastic anemia is usually due to protoferrin ring mutation, right? Or not mutation, but protoferrin ring malfunction. And this can be due to a number of reasons, like alcohol. It could be congenital. It could be due to B6 deficiency, isoniazid. And in this case, again, we're going to damage our ALA synthetase and our ferrochelatase. And so again, heme synthesis is not going to be going totally as it should. And in this case, iron is totally normal. So iron gets deposited to the mitochondria, but then it has nowhere to go because we can't make our heme molecule, so it gets stuck around the outside of our cells. And so that's why you might see those ring sideroblasts. And again, in all these microcytic anemias, we think about if the heme molecule is not able to be fully made, right, our red blood cells are going to get smaller, smaller, smaller. As our bone marrow is trying to pump out more red blood cells, it's trying to keep the concentration of hemoglobin as fixed as possible. So as my red blood cells get, the bone marrow has to make the red blood cells get smaller, smaller, smaller to keep the hemoglobin kind of around the same concentration until it can't anymore. Then we can think about a normocytic. I like to break down normocytic into hypoproliferative and hyperproliferative. So hypoproliferative tells me that there's probably a problem with the bone marrow. There's a hard time making out reticulocytes to increase the red blood cell count. So those can be due to chronic kidney disease, anemia of chronic disease earlier on in the course. It can be due to hypothyroidism as well. So those are some of the big ones. And then like bone marrow failure, which is just like a broad term. And so we'll talk about chronic kidney disease coming up and anemia of chronic disease. Hypothyroidism can also lead to a decrease in erythropoietin, which can lead to a hyperproliferative hypoproliferative response. And then we also have bone marrow failure, where there's a million of causes, and again, that could be its own lecture, but damage to the actual hematopoietic stem cells. So then we have hyperproliferative normocytic anemia. So those are going to be my 3 H's. They're going to be hemolysis, hemorrhage, and hypersplenism. I plan on doing a whole lecture on hemolytic anemia because that's such a complex topic as well. But in this case, we have damage to the red blood cells out in the periphery. The bone marrow is totally fine. So in this case, it's able to compensate by producing an increased amount of reticulocytes to compensate for the low hemoglobin or the low red blood cell count. Then we move over to our macrocytic. So again, these are going to be over 100, the MCV. And we can have megaloblastic and we can have non-megaloblastic. So in megaloblastic anemia, this is going to be a problem at its core with DNA synthesis. We think about B12 deficiency, folate deficiency, copper deficiency are going to be big ones, and then certain drugs too, like hydroxyurea is known to cause a megaloblastic anemia. Then we have over in our non-megaloblastic macrocytic anemia, this is more of a problem with the membrane, where the membrane gets altered and where it just end up making larger red blood cells. So those are going to be due to liver damage, alcohol, reticulocytosis, and myelodysplasia. Again, I've gone through this kind of framework like several thousand times probably in my head, and you can just kind of get it into memory. But it's a good starting place if you start with microcytic, normocytic, macrocytic, and then just keep practicing over and over and over again until it becomes second nature. So if we look at our patient's question, right? So now we've got a little bit of a framework of anemia. We're asking for the step 1 questions. What is the pathophysiology behind the patient's anemia? Well, she has a normocytic anemia. So we kind of think about, okay, are we hypoproliferative or hyperproliferative? In this case, there's actually a little trick that we're going to cover in the step 3 section. But really, we can look at it and we can say it's a normocytic anemia. They have chronic kidney disease. It's a step 1 question. They're probably going to be testing me on chronic kidney disease anemia. So the pathophysiology behind this patient's anemia is going to be that there's a lack of EPO production, right? My EPO is made in my peritubular fibroblast. It normally gets made, it goes to the bone marrow, it stimulates hematopoietic stem cells to keep being proliferative and keep making more reticulocytes and more red blood cells. In this case, when a patient has chronic kidney disease, those peritubular fibroblasts are damaged. I can also tell that this is a hypoproliferative anemia because the reticulocyte count is within normal limits, and that's abnormally normal, okay? So this is like a tricky concept because when you have a patient who has anemia, the normal response should be a massive reticulocyte count jump, right? It should be like 5%. It should be higher, way higher than 1%, which is in normal limits. So the fact that it's within normal limits is actually abnormal. It should be high. And we'll talk about a cool little trick in the step 3 questions on how we can actually calculate a more true reticulocyte count. So then I want you to think about for step 1, how do you explain the patient's calcium abnormality? So we look and the calcium is low, it's 8.1, and the PTH is sky freaking high. So in this case, right, when we think about my PTH calcium axis, right, I have 4 parathyroid glands, they sit right next to my thyroid. They have GPCRs that sense calcium. When calcium is normal or high, it shuts things down. When calcium is low, the parathyroid goes and it does its job, right? It goes to the bone and it chews up bone, and we get phosphorus and calcium. It goes to the kidneys, and in the proximal convoluted tubule, it's going to activate 1-alpha hydroxylase, and it's going to cause vitamin D from my liver, When it makes its way down to the kidney, that vitamin D, that 25 OHD, runs across this enzyme and it turns it into 125 OHD, which is the metabolically active form of vitamin D. That metabolically active form of vitamin D goes to the gut. It's a steroid hormone. It's going to increase gene regulation and alter that and cause increased calcium reabsorption. Parathyroid hormone also in the kidney. It's going to cause the dumping of phosphate or phosphorus into the urine. So we're going to pee it out. That happens mostly in the proximal convoluted tubule. And then in the distal convoluted tubule, it causes the sparing of calcium, right? It causes the reabsorption. So all in all, PTH is going to cause the saving of calcium. So it should raise calcium, and it causes us to dump phosphate into the urine. So it is saving calcium increase and decreasing phosphate. When I take a look at this patient's labs, the PTH is really high, but that phosphate is also really high. And so that tells me something's up here. So in a patient who has chronic kidney disease, their vitamin D, right, their 1-alpha hydroxylase that sits in the proximal convoluted tubule is also getting damaged. So in this case, the patients, even if they're eating normal vitamin D amounts, if they're getting normal sunlight, that's the 25 OHD that sits in my liver. That's not metabolically active. Even if that makes its way down to the kidneys malfunction. It's not going to be able to effectively and efficiently convert 25 OHD into 125 OHD. So this patient is going to have a low level of 125 OHD, and that can lead to low calcium. The patient's kidney tubules are also messed up, so they're not able to effectively excrete out phosphate, and phosphate builds up. When phosphate builds up and it's in the gut, it can bind to calcium and cause a decrease in calcium that way, right? It binds up calcium, there's less free calcium. So there's the two mechanisms of low calcium there. And that's also, we're kind of explaining why the phosphate is high. So when my parathyroid glands, they sense the low calcium, they're going to increase parathyroid hormone big time, right? It's going to chew up my bone, and it's going to try to do the work in the kidney and the gut via vitamin D, but it's not going to work too well, right? So that's how I think through this. It's not primary hyperparathyroidism, because in primary hyperparathyroidism, it's a problem in my parathyroid glands that are shooting out too much parathyroid. They go down to the kidney and the bone and work in the gut via vitamin D, and my calcium should be really high. So when I think about primary hyperparathyroidism, the PTH is either high or it's abnormally normal with a high calcium, because normally calcium should feed back and shut it down. So even if my calcium is high and my PTH is within normal limits, that's again abnormally normal, because high calcium should feed it back. In this case, there's low calcium and abnormally high high PTH. So that tells me something's wrong in the kidneys, right? And my PTH is responding, my parathyroid glands are responding appropriately. I'll do a whole lecture on parathyroid hormone, because I think that one deserves a lecture too. But that's how we explain that. And then why is the platelet aggregation assay normal? So the platelet aggregation studies are like the gold standard for looking at platelet malfunction. So we have things like bleeding time, which was the old test to look at like platelet dysfunction. We have things like the platelet function analyzer, and now we have things like the platelet aggregation assay. So our platelet aggregation assay was abnormal, even though the platelet count was normal. In this case, it's likely secondary to the chronic kidney disease. So when the urea toxins get up, because remember, urea is excreted out in the kidney. When that urea keeps getting up, and up, it causes malfunction in the way the platelets interact with the endothelial cell wall and with each other. So remember, platelets binding to the endothelial cell wall and von Willebrand factor is GP1B. Platelets binding to each other happen between GP2B, 3A. And so the platelets have GP2B, 3A, they bind a fibrinogen, and then they bind another platelet, and they go. So there's abnormalities with the increased urea causes abnormalities in that. We also know the increased urea causes malfunction in the nitric oxide metabolism, and the nitric oxide itself can cause platelet malfunctions with both secretion, adhesion, and aggregation. So whenever you're thinking about a patient with chronic kidney disease, always think about platelet malfunction, okay? Their platelet count can be normal, but the platelets aren't working totally the way they should. Step 2 question, so how should we treat this patient? For this patient, one, we're gonna wanna treat their underlying problem, right? Before, this is a classic step 2 question, is before we jump to treating them with EPO, we should work them up for other causes of anemia. So we should work them up for iron deficiency anemia. Heck, we can even work them up for B12 and folate deficiency. It gets tricky because you could have a patient who has both iron deficiency anemia and, let's say, folate deficiency anemia, okay? That's a macrocytic and a microcytic, and it'll put me right into the normocytic range, right? When we think about my MCV. So if like half my cells are microcytic, half my cells are really macrocytic, we're going to get a normocytic MCV. So that's why, like, don't be just fooled by the normocytic MCV. So first things first, we should work up for other causes of anemia. And we're going to look at the KDIGO guidelines coming up for step 3 on when we do iron replacement in this patient. So that's kind of how we would treat that. If we don't find another cause, then we can consider giving EPO, okay, or erythropoietin stimulating agents. So that would be like the ultimate treatment, right? Especially if the hemoglobin's less than 10, that's indication there. And so then what are some side effects of the treatment for this patient's anemia? Well, if we give them EPO, right, it's going to stimulate the increased production of red blood cells. And I like to kind of think about it like polycythemia vera, right? That's a real increase in hemoglobin and hematocrit. What can happen in those patients? We can have hyperviscosity syndrome. So hyperviscosity syndrome, I have too many red blood cells. They get clogged up in small little arteries. We can get headache. We can get blurry vision. We can get numbness, tingling in the fingers and toes, right? Things like that. So we can also have hypertension and the risk for stroke, right? If some of those really sticky red blood cells get up to my cerebral arteries up there. So that's your step 2 questions. Step 3 questions are based on the KDIGO guidelines. What are the indications for iron replacement in CKD? They have very specific guidelines, and you can read about them. The ones that are most commonly cited are you get an iron panel and a ferritin. If your ferritin is less than 500 and your transferrin saturation is less than 30%, that's indication for iron replacement therapy. Okay, so you can look up online the KDIGO guidelines. What is the pathophysiology of tertiary hyperparathyroidism? Well, in this case, the patient likely has long-term kidney damage. Their low calcium is lessening the feedback to parathyroid hormones, and my parathyroid glands just get bigger and bigger and bigger until they get a mind of its own. And this classically happens after the kidney is transplanted. So now the patient has a functioning kidneys that are absolutely responding to the parathyroid. And the parathyroid gland is freaking huge, right? The 4 of them are freaking huge because of the lack of the calcium negative inhibition for all this time. And now the kidneys are able to respond, and that patient's calcium is going to go way up. So you're going to see a super high PTH, a super high calcium, and the patient could have some bone problems too, right? That's called renal osteodystrophy, where this increased PTH is activating all my osteoclasts and they're chewing up all the bones. The last step 3 question is to calculate the corrected reticulocyte count for this patient. So to do this, we take their reticulocyte count that we got in the stem, right? So whatever we calculate in the lab, it's 1%. We multiply that by their hematocrit. So their hematocrit here is 27%. And we divide it by the normal hematocrit, right? I consider like normal hematocrit is 45 in men and 40 in women. So if we do that math, it's 0.6. And now that's a low value, right? That's like now it's signifying an abnormal response, an abnormal bone marrow response. So we get a better picture of that. Another like key tip here is usually the hemoglobin times 3 should equal the hematocrit. It usually works out somewhere along those lines. And then just some quick integration questions here. What is the Menser index? So the Menser index, you take your MCV, you divide it by your red blood cell count, and then that gets you a value. And so the red blood cell count's usually in the millions, but you just like forget the millions. So like if my MCV is 90 and my red blood cell count is 3 million, I do 90 divided by 3. And in this case, we use a cutoff of 13. This test is really good to tell me, is this thalassemia or is this iron deficiency anemia, or at least like point me into the right direction. If the value is greater than 13, it points me more towards iron deficiency anemia. If the value is less than 13, it points me more towards thalassemia, right? So if I do the Menser index, the classic step question is, they'll give you a patient who has both heavy menstrual bleeding and is from like Greece. And you're like, wow, this could be both thalassemia and iron deficiency anemia. And they won't really give you anything more. They'll give you an MCV, they'll give you an RBC, and they'll say, what's the next best step? You'll calculate the Menser index. If it's greater than 13, let's get an iron panel on her. If it's less than 13, let's go do hemoglobin electrophoresis and look for alpha or for A2, right? Which is the classic thing we'll see on hemoglobin electrophoresis for beta thalassemia. My next question is, what is the pathophysiology of anemia of chronic disease? This has to do with increased IL-6, which activates hepcidin, an acute phase reactant, and it causes the storage of iron and ferritin, right? Iron in the storage form is ferritin, into the reticuloendothelial cell system, right? So it's keeping iron trapped into the liver, so it can't go out and go to all the other cells that we need it to, right? So in this case, the best way to tell iron deficiency anemia from anemia of chronic disease is to look at your ferritin and your TIBC. So normally in anemia of chronic disease, that ferritin will either be like normal or it'll be slightly elevated. The TIBC will be low because there's less transferrin for the iron to bind to because there's less iron available. In iron deficiency anemia, the ferritin is usually low because we're losing all the iron out of our body via somehow, right? And the TIBC is high, right? I think about the TIBC as like a school bus, and it's just waiting for space for iron to bind, right? Because there's less iron in the system. The school bus just has all these open seats waiting for iron to bind. Okay, so like that patient still has iron in their system. It's not locked away in jail like it is in anemia of chronic disease. There's just less of it. Whereas in anemia of chronic disease, it's locked away in jail. We can't use it. Okay. And then my last question is, how do we distinguish B12 deficiency from folate deficiency? Both of these can cause a megaloblastic macrocytic anemia. Remember, we can get a peripheral smear, which might show hypersegmented neutrophils due to this abnormality in DNA synthesis where the nucleus is really slow to mature, but the cytoplasm matures really quickly. Both of them are classic like step questions, right? So folate deficiency usually happens pretty quickly, like it can happen in like a couple months. B12 deficiency usually takes many, many months to years. Folate is found in foliage. B12 is found more in animal products. Both of them can cause a elevated homocysteine. They're both used in homocysteine metabolism. And if we have a lack of them, the homocysteine builds up. Remember, homocysteine itself can be, it can really activate your clotting system. It can cause a lot of clots and strokes. With regards to the differences then, is B12 likely will cause an elevated MMA, so methylmalonyl-CoA mutase, or methylmalonic acid. B12 is a cofactor for methylmalonyl-CoA mutase. So if I don't have B12, right, we can't convert methylmalonyl-CoA mutase or methylmalonic acid into succinyl-CoA via methylmalonyl-CoA mutase, right? A lot of words there. Let me just say it one more time. So like if we don't have B12, we don't have a functioning cofactor for methylmalonyl-CoA mutase. So I can't take methylmalonic acid and convert it to succinyl-CoA. So methylmalonic acid builds up. With regards to folate, you won't see that because folate is not a cofactor for that enzyme. Other ways we can tell them apart is B12 deficiency can classically have our neurological symptoms, right? That's called subacute combined degeneration. So that's SCD. And the SCD can also like works out to be the spinal cord pathways that are usually cause problems in these patients, right? So the S is the spinal cerebellar, so those patients could have gait ataxia. The C is the corticospinal, so they could have weakness, and the D is the dorsal column medial lemniscus, so the patient can have lack of vibration and proprioception, right? They can be unsteady on their feet. Folate, you won't really see that, right? We can do things like test for their B12, we can test red blood cell folate levels as well. So those are some key things on anemia. We specifically focus on like anemia of kidney disease. We talked about some other complications of kidney disease. So let me know your thoughts in the comments and what other lectures I should do.